Osteoporosis is a devastating illness that is highly prevalent, the incidence of which is on the rise as populations age around the world. Doctors prescribe treatment for osteoporosis based on criteria that are recommended by various authorities. These include a bone mineral density that is 2.5 standard deviations below the mean bone mineral density of a young woman, or people above the age of 50 who suffer fractures of the hip or of the spine, regardless of their bone mineral density. Thirdly, they may prescribe medication if a patient has osteopenia or thinning of the bones and a fracture risk, a 10-year fracture risk for a major osteoporotic fracture of equal to or greater than 20%, or a hip fracture risk that is equal to or greater than 3%. But these medications can have serious side effects, making some patients reluctant to take these medications. But are these fears justified? Like in any other medication, the decision whether to take a medication or not to take a medication is based on the benefit-risk ratio of the medication. If the benefits of taking a medication do not outweigh the risk of taking that medication, then taking that medication may not be a good proposition. On the other hand, if the benefits of taking that medication outweigh the risks, then there's good reason to take that medication. So let's examine the benefits of taking medications for osteoporosis. The first-line treatment for osteoporosis is the group of medications known as bisphosphonates. Before we can have a meaningful discussion of risk reduction in osteoporosis, we must first differentiate between primary prevention of osteoporotic fractures and secondary prevention of osteoporotic fractures. Primary prevention of osteoporotic fractures means prevention of fractures in patients who have never suffered a fracture before, whereas secondary prevention of osteoporotic fractures involves the prevention of fractures in patients who have already suffered a fracture sometime in their past. The ACP conducted a study to examine risk reduction in osteoporotic patients treated with bisphosphonates. This study included patients from both groups, primary and secondary prevention of osteoporotic fractures. That study showed that bisphosphonates decrease all clinical fractures, that is, fractures that were symptomatic, by 2.4%. Here we're talking about absolute risk reduction as opposed to relative risk reduction. We will focus on absolute risk reduction because relative risk reduction produces larger numbers that can sometimes be misleading. That means that if we were to treat 1,000 patients with osteoporosis with bisphosphonates, we would spare 24 people from suffering a clinical or symptomatic fracture. That same study demonstrated that bisphosphonates decrease the risk of clinical vertebral fractures, that is, fractures of the spine that were symptomatic, by 1.8%, and decrease radiological vertebral fractures, that is, fractures of the spine that were diagnosed only by X-rays, by 5.6%. This means that if we were to treat 1,000 patients with bisphosphonates, 18 would be spared clinical fractures, that is, symptomatic fractures, and 56 would be saved fractures that are only diagnosed by X-rays. With regards to fractures of the hip, the American College of Physicians study showed a reduction in the absolute risk for hip fractures by 0.6%, whereas the United States Preventative Services Task Force study, which included only patients who were diagnosed with osteoporosis based on densitometry and not patients who had suffered a fracture sometime in the past, there was no benefit to be derived in the reduction of hip fractures with the use of bisphosphonates. A reduction in the absolute risk of hip fractures in patients taking bisphosphonates was only seen in patients who had had a fracture sometime in the past. Let us now examine the risks of taking bisphosphonates. Osteonecrosis of the jaw is estimated to occur in 0.01% to 0.3% of patients who take bisphosphonates for at least 2 to 3 years. This means that if we were to treat 1,000 patients with bisphosphonates, we would expect to see a maximum number of 3 patients with osteonecrosis of the jaw. For atypical fractures of the femur, the estimated incidence is 0.56 per 10,000 patient years. This means that for us to see one case of a typical fracture of the femur, we would have to treat 1,000 patients for 18 years. These figures clearly demonstrate that the benefits of taking bisphosphonates outweigh the risks of these 2 major complications, and therefore the use of bisphosphonates in the treatment of osteoporosis is justified when indicated. We should, however, remember that these 2 complications increase substantially if the treatment duration is extended beyond 2 to 3 years in the case of osteonecrosis of the jaw and beyond 5 years in the case of atypical femoral fractures. It therefore is important for us to avoid taking these medications beyond a period of 5 years. On the other hand, we can clearly see that the benefits derived from bisphosphonates are moderate, and therefore the decision to initiate treatment in a patient should be a joint decision between the patient and the doctor based on the patient's risk profile. I hope you found this video informative. If you did, like and share the video with your friends and family. Support the channel by subscribing. Until the next video, stay healthy and stay safe.